2, 1, go.
Good evening, everyone. I'd like to welcome you again on the clinical webinar on CEC. Our topic today is prosthetic heart valves. As we all know, the management with prosthetic valve is replacing a disease with another disease. This means we need special consideration regarding the choice of the valve, the follow-up and management of the complication we may encounter with prosthetic valve. We have a fantastic team today to discuss this important issue. Our speakers today will be Professor Dr. Hatem Sukkari, Associate Professor of Cardiology, Tanta University, Dr. Ahmed Farid, Lecturer of Cardiology, Suez Canal University, and Dr. Mohammed Medhat, Lecturer of Cardiology, Bani Suef University. This will be together with great moderation from Professor Dr. Tamer Mustafa, Professor of Cardiology, Zagazig University, and Professor Dr. Ala Omar, Associate Professor of Cardiothoracic Surgery, Cairo University. So I hope you all very fruitful time, and I'll pass the mic now to Professor Dr. Hatem Sukkari to present the first case scenario in prosthetic valve webinar. Dr. Hatem, please.
Assalamu alaikum rahmatullah. Today we will speak about prosthetic valve disease on case-based discussion. I will start with a case scenario, and then after I finish, I will leave the mic for my colleagues to continue about valve obstruction and fantastic case. We will depend on the guidelines of European Society of Cardiology for the Management of Valvular Heart Disease 2017 and the guidelines of 2018 for pregnancy and heart disease. Let's to say in 1952, the first mechanical heart implantation, valve implantation, and in 1962 was the successful biological or bioprosthetic valve was implanted. So the introduction of valve replacement surgery in early 1960 has dramatically improved and with outcome. Despite this improvement in prosthetic valve design, surgical procedures, valve replacement, we doesn't provide a definitive cure. Still we have a problem. So instead to have native valve disease, now we have prosthetic valve disease. This is the started mechanical valves. We start Edward and then go for lastly St. Jude, which is the most valves available patients now by leaflet. And this is the new generations of mechanical tri-leaflet valve, and also the bioprosthetic valve, which is stented or stentless. Let's to start our case scenario. We have a female patient, 30 years old, with history of rheumatic heart disease. She is married, has one child, 3 years old. Her last pregnancy was uneventual and with normal vaginal delivery. She presented complaining of shortness of breath with NIHA class 3. Transthoracic echo Doppler revealed severe mitral regurg, rheumatic heart disease, severe mitral regurg, mild mitral stenosis, mitral valve area 2, and left ventricular ejection fraction 55. So the first question for our attendees and for ourselves, what's your plan of management? What's our plan? Start medical therapy in the form of diuretic therapy and do follow-up for her after 6 months, or go directly for mitral valve replacement.
عشان نرجع سلايد كده دكتور حاتم لو سمحت. one slide.
نعم.
نرجع one slide back.
نرجع one slide back. Again, she is 30 years old. She has one child since his 3 years old. She is complaining of shortness of breath, and she became NIHA class 3. And her echo revealed severe mitral regurg, mild mitral stenosis, ejection fraction 55. So to choose medical therapy was start with diuretics and follow up after 6 months, or to go for mitral valve replacement? Can Dr. Ahmed Saeed and Dr. Haytham check for the attendees in YouTube? Answers?
I will ask you, Dr. Hatem, to wait for 1 minute to overcome the delay between the Zoom and the YouTube. But we've received some answers about mitral valve replacement so far.
Dr. Hatem.
From the YouTube.
Dr. Hatem.
Yes, Dr. Ala.
Can you give us a summary about here dimensions, the end-systolic dimension and systolic dimension?
Yes. Ejection fraction, details pulmonary hypertension, AF or not.
She is not atrial fibrillation, she is sinus rhythm.
Yes.
She is sinus rhythm. No pulmonary hypertension, just
end-systolic dimension is very important for us in managing mitral valve surgeries.
End-systolic dimension 4.7, as I remember.
Yes, 4.7. 4.7. This is a large dimension where we usually proceed for surgery in mitral regurg if the end-systolic dimension is larger than 4 centimeters. This is a key point in our management.
This patient did not do any follow-up after delivery, so she stayed 3 years without follow-up until she started to become dyspneic. And then she came without any medication, then started to complain, and then she asked for advice. And as we not,
what about the dimensions of the left atrium?
Dimensions of the left atrium, 4.6.
4.6. This is maximum diameter.
Maximum by M mode.
So we're receiving answers from YouTube preferring mitral valve replacement, which is B. There is one opinion of to start medical treatment with diuretics and follow up after 6 months, but most of the answers are with mitral valve replacement.
Can I take opinion of Dr. Ala regarding this case? What's your opinion if you receive this patient for mitral valve replacement? Shall you proceed or you let her to try medical treatment?
If this patient is in this situation is a symptomatic patient, NEHA class 3, if the end-systolic dimension of this patient is more than 4, I will go for surgery. But before going for surgery, I like to know her Wilkins score for feasibility of repair. I want to know the morphology of the mitral valve, because nowadays, especially in a female 30 years old with one sibling, she may need to have more babies, and she's in sinus rhythm, which is very good thing. If we can go for mitral repair, this will be much more better than valve replacement. Actually, most of regurgent lesions are repairable, more than stenotic lesions, if the Wilkins score is fine. So if this patient have a nice morphology, end-systolic dimension more than 4, I will proceed for mitral valve repair as a priority.
Dr. Ale, please, Dr. Ale, I want to ask about if you have a rheumatic mitral valve disease with mitral stenosis. Do you want to proceed here with repair in some cases?
Yes, if she is in childbearing period.
And mitral stenosis.
Yes, if she is in childbearing period, I will prefer to give her a chance to repair the valve, but on some circumstances that the Wilkins score is favorable. I know that the combination of mitral regurg with mitral stenosis usually end up with mitral valve replacement. But in this situation, in this young female, I think that she deserves to have a mitral valve repair trial if the Wilkins score is good, if the subvalvular apparatus was not severely affected and no massive calcification, I can proceed here for mitral valve repair.
So, Ala, if I asked you, what are the criteria to let you to go with repair in this patient? Childbearing period, young age.
Yes.
What are the criteria favoring repair over replacement?
Yes.
From cardiothoracic point of view.
Yes. We like to repair the valve if the morphology is good. If the Wilkins score is 8 or less, we can go for repair if this is the criteria I present. We like repair in those patients because they are in sinus rhythm, so they will avoid long-standing marivanization and we will be out of the dilemma of anticoagulation during pregnancy in this young female.
What are the questions you will ask the echocardiographer to answer you before you take your decision?
Yes,
what are the data you are needing from the echocardiography?
Yes, the most important data are the Wilkins score. I want to know how the subvalvular apparatus is, because many of repairs fail finally due to poor situation of subvalvular apparatus, because too short chordae or amalgamated or too short papillary muscles will need sophisticated techniques to correct. And if you do many sophisticated techniques, eventually the prognosis of mitral repair will not be favorable, and the 2 years follow-up will be bad. So the most important is Wilkins score for me to repair the mitral valve. The second thing is to know the description of the posterior scallops, yes. P1, P2, and P3. If there is an area of redundancy, if there is an area of shortened chordae, this morphology is very important to know if I'm going to put artificial chordae, where I will do it. So the morphology of the posterior mitral leaflet and the Wilkins score, especially the subvalvular apparatus, actually also the anatomy of the commissures is very important in the setting of mitral repair in rheumatic patients.
And this is what I mean when I give only poor echocardiographic data, and that you started to ask me frequent questions. I was intended, as I found a lot of cardiologists give not enough data for mitral valve repair. They just said severe mitral regurg, mild mitral stenosis, symptomatic, and think about mitral valve replacement. Whatever you will replace, you will do repair or what you will do replacement, tissue valve, mechanical valve. All this story you should discuss it in details. You should give us account about the morphology of the chordae, the morphology of the commissures, the Wilkins score. All this is very important for the surgeon.
Yes,
that's
sir.
Correct? Yeah.
Yes, this is very important.
Regarding
Actually,
this thing, yeah.
As you said, sir, we always have a problem that some echocardiographers let us know only that there is severe mitral regurg. No description of the valve, which is something we cannot judge how we are going to repair this valve without knowing its exact morphology.
Yeah. If the valve ring is dilated, you will put, if the valve annulus dilated, you will put a ring.
Yes.
Or just you will do repair for the valve, only the suture.
Yes, sir. You are correct, sir. We need to know all this data because mitral valve repair is usually a preoperative decision. Yeah, you know, sir, that you are going from the start to repair this valve. So you have to know all the information needed to make a good plan of repair, because if you know those all informations, you can make a clear decision from the start and avoid wasting many time on bypass.
Okay, there is two important questions from the YouTube to complete this picture, Dr. Hatem. I'm terribly sorry for interrupting.
Yeah.
But one of them, Professor Sergio Moreno is asking about the role of tissue Doppler and the intensity of S wave in tissue Doppler in estimating or sharing the decision in this mitral regurg or this case. This is the first question. The second question is for both the cardiologist and the cardiothoracic surgeon, is if we judge any patient with double mitral rheumatic valve, mitral regurg, and mitral stenosis, that this patient is not suitable for repair, and this patient is directly for mitral valve replacement or not. These are the two main arguments now on the YouTube.
Dr. Tamer, can you start, answer the first question, and I will answer the second question, please?
Yes. From point of view, use of tissue valve in rheumatic, it was not
tissue Doppler, sir. Tissue Doppler.
Yes, sorry.
Yes, the estimation of the S wave at the tissue Doppler parameters.
I think this is an additional factors may be added on the basic. The basics will be the anatomy, the Wilkins score, the chordae. I think this is more basic than the tissue parameters. Sometimes in some confusing cases or to take some decision, you can make some refinements using the tissue Doppler. But basically, the anatomy and preferred to have a transesophageal look is basic for the decision.
I think also transesophageal is very important before decision of repair.
Yes.
Regarding the second question, Dr. Ala,
Yes, sir.
most of us thinking that if the patient is double mitral lesion, mitral stenosis and mitral regurg, so we should go proceed for valve replacement, not repair. What's your opinion?
No, sir. This is an old-fashioned way of thinking. All guidelines and all surgeons now are really interested in mitral valve repair because it's very superior to mitral valve replacement. As you said, sir, replacing a mitral valve with a prosthetic valve is replacing a native disease with a prosthetic valve disease. And we saw many complications from prosthetic valves and malformation. So we should not go easy for mitral valve replacement. We should always give a trial of mitral valve repair. The most important for me, for a patient to have combined mitral regurg and the mitral stenosis traumatic valve, is to assess the morphology of the valve. For example, last week I had a patient, female patient, 34 years old. She has a mitral valve area of 1.8. She has severe mitral regurg, but her Wilkins score is 6. She has no fused commissures. I went for commissurotomy. It was very simple commissurotomy, and I repaired the valve finally by putting a ring. And she had an eventual postoperative course with a very good echo. I hope it will remain good for a long time. So the dictum of having combined mitral stenosis and regurg in a rheumatic patient will go in favor of mitral valve replacement is no more valid. The possibility of mitral repair should be always present in every patient if the morphology of the valve is favorable.
So I think we go first for Wilkins score, which is not enough. If Wilkins score at 8 or less, we will go for other parameters that favor repair over replacement. But if Wilkins score is high, it is enough to say for go for replacement.
Yes, sir. If Wilkins score is like 9 or higher than this, in presence of significant mitral regurg, I think that the durability of repair will not be that good.
Do you have a cases that when you go for decision of replacement and after you start the operation, you found the valve is favorable for repair and you change your opinion?
Many times. When you go for echo and Wilkins score and you make a preoperative decision that this valve is not worthy to be repaired and you go for replacement and save the time for the patient on the heart-lung machine. But many times, when I go inside the left atrium, I find that this valve is good. This valve need a chance to be repaired. And in like 80 to 90% of cases, I change the decision and go for repair. I am a believer that repair is the best option for mitral valve whenever it's possible, and every patient needs a chance to be repaired before to be replaced.
Okay, regarding our patient here, Wilkins score was 7 by the parameter and dimensions, and this Wilkins score, do you think it is preferred to go for replacement or repair?
Yes, if the Wilkins score is really 7, and when I open the valve, there is no shortened chordae, and there is no prolapse of one of the scallops of the posterior leaflets, I will go for repair this valve. In this age group, I will repair this valve.
If you go for replacement, it is preferred to leave the subvalvular apparatus?
Yes, sir. This is a very good question, Dr. Had. I always, not almost always preserve the subvalvular apparatus. Sometimes I prefer both subvalvular in the anterior leaflet and posterior leaflet, because I believe, and I saw patients, that when you cut the continuity between the mitral valve and the mitral apparatus in the left ventricle, papillary muscles and left ventricle, they come after 10 or 15 years by very low ejection fraction, despite the valve is functioning very nice. Something like postoperative cardiomyopathy in this patient. So, like 10 years ago, I stopped cutting the continuity between the mitral valve leaflet and the left ventricle. I preserve both leaflets, and there is recent measures that's called the Mickey procedure or something like this to cut the scallops of the anterior leaflet to preserve both leaflets. I think that in mitral regurg, the mitral annulus is large. It can accommodate for a large valve, so you can preserve both leaflets. And whenever it's possible to preserve both leaflets, go for this.
Okay, can we continue, Dr.
Can I ask a question, please?
Yes,
sorry. What are the causes of patient post-mitral valve repair? We found a decrease or decline in the ejection fraction or the function of left ventricle post-surgery within few months. What are the suspected causes to surge in that cases?
Yes, sir. I think that's the most important case scenario to have jeopardized ventricular contractility after operation if the patient has a normal ejection fraction from the start is poor myocardial protection. Poor myocardial protection during the mitral valve repair surgery is a longer duration operation than valve replacement. It needs time and planning. When you are not critical in having your cardioplegic solution at the regular intervals, sometimes I saw patients like this go after the bypass and remain for up to 6 months with diminished ejection fraction. So poor myocardial protection is a cause. Another cause that is rare, but I saw it sometimes, when you go for deep stitching, when you make a posterior aneuplasty ring, sometimes some surgeons may take deep sutures in the posterior part of the mitral annulus. This sometimes, I say sometimes, not usual, but sometimes may affect the circumflex artery.
I saw one case like that. Yeah, I have one patient. Yeah,
yes, sir.
Deep sutures, and he make proximal circumflex total occlusion with resultant myocardial infarction and poor contractility segmental.
Yes, this happens. It should not happen, but this sometimes happens if a surgeon is not that accustomed with mitral valve repair, not accustomed to take, not superficially. The problem is what if you took a superficial sutures, it will make a ring dehiscence. If you take deep sutures, you may suture the circumflex artery, and this will be a big problem in the post-operative course. This is something comes with learning curve with time, but this is the most common causes of jeopardized ejection fraction after mitral valve repair surgery.
Okay. Another question, please, before continuing. Patient with borderline ejection fraction. Are there any precautions during surgery to preserve this borderline patients? Borderline ejection fraction.
This is a very good question, and there is very ultimate precautions. First of all, you have to preserve both mitral valve leaflets. This is a dictum. If a patient has jeopardized contractility, you have to preserve both leaflets. If you cannot repair this valve, go for replacement. And actually speaking, if you have a borderline contractility, go for replacement from the start, but preserve both leaflets.
I agree.
This is my dictum. Do not be very sophisticated, because if you are very sophisticated, you will lose the patient. If you have a patient with ejection fraction 35% and you insist to repair this valve, and he came in the early postoperative course with mild regurg, this ventricle will not accustom for this volume overload and will fail, and you will lose your patient. In these situations, be determined from the start. Preserve both leaflets, put your valve, you will have a nice postoperative course. This patient will have a good life.
Okay, let's continue. We have a lot of information. As per guidelines, the mitral valve repair should be the preferred technique, as Dr. Ala said, when results are expected to be durable. And surgery is indicated in symptomatic patient with left ventricular ejection fraction more than 30%, and our patient is 55 and symptomatic. So we will go for mitral valve repair or replacement, and they took the decision to do for her mitral valve replacement. We know that mitral valve, as you said, preferred method, but mitral replacement should be considered if unfavorable morphological outcome. Characters. Outcome of mitral repair depend on the surgeon experience and center-related volume. And this is why they choose to do mitral valve replacement. So the second question, which type of replacement you would choose for this patient? Mechanical, metallic valve, or bioprosthetic, which is tissue valve? Let's go for 1 minute for YouTube, please.
Excuse me, Dr. Hatem.
Dr. Ahmed, Dr. Aysam, I don't listen.
You hear me? Dr. Hatem?
Aywa?
Dr. Muhammad, we can't hear you very well.
Yeah? Very?
No, we can't hear Dr. Muhammad Medhat very well.
This is good. Now good.
Yeah,
Now good.
yeah.
Yes.
Okay. Till the answer come, I have one comment on the most common cause of left ventricular dysfunction after mitral valve surgery. I think late intervention. The patients with mitral valve disease and especially mitral regurgitation usually become symptomatic when the left ventricle loses some of the function, and the ejection fraction is deceiving because the left ventricle is pushing against a low pressure chamber, which is the left atrium. After closing this low pressure chamber, the ventricle have to face the aorta and the systemic pressure. Suddenly, after closing the pathway of the mitral regurgitation, and the patient had lost some of its contractile reserve.
A very good comment, Dr. Mohammed. A very good comment.
Yeah.
So the guidelines always now tell that we have not to wait until the ejection fraction is less than 50. If there is a good chance for repair, do not wait the ejection fraction to be less than 50 or the end systole to be more than 4 centimeters. Go early for repair if the repair is visible, because you said what is happening usually. We conserve for a long time, and the ejection fraction is deceiving in cases of mitral regurg. And finally, after correction, we have a jeopardized contractility.
Okay, we have.
So the message here, please. Sorry,
Most of
sorry for
the
interruption.
votes from the.
Okay.
No, most of the votes
Item,
from YouTube. Okay.
Okay. The key message here is for doctors. Don't no inertia for taking a decision once ejection fraction is 55 or less. You can take a decision early, because if we go to 50, we have a chance for sometimes deterioration post surgery. So don't be energetic.
A very good take-home message. A very good take-home message.
Okay, Dr.
Okay,
Haitham.
Okay, the votes from YouTube are voting for mechanical prosthesis, and some of them are saying that she has already 3 children. So
One child. 3 years ago, one child.
Yes.
3 years ago, one child.
Mm.
So I think they were misled, but most of the votes are voting for mechanical prosthesis, and I myself is
I go
favoring
for
mechanical prosthesis.
Despite she has only one child. You know why? Let's see how to choose. You choose mechanical at any age if there is indication for long-term anticoagulation. If the patient is atrial fibrillation or history of DVT, recurrent pulmonary embolism, whatever you have a history that the patient is in anticoagulation lifelong, you will go for mechanical. If the patient is contraindicated for anticoagulation, whatever his age, he will go for bioprosthetic. For our patient, he has no problem for both. If the age is less than 50 years old with no contraindication for anticoagulation, like this female, we will go for mechanical. If the age is more than 70, we will go for bioprosthetic. The gray zone between 50 to 70, it is patient preference. If the patient prefer tissue or prefer mechanical. The most important in this specific patient, our case, is the high risk of re-intervention. If the age is less than 40 years old, the patient has a high risk for re-intervention, especially with pregnancy and so on. So structural heart disease for tissue valve is most common. So they prefer for mechanical. But if there is low risk of re-intervention, you will go for tissue valve. And this is what's it. As we said in the guidelines, that mechanical prosthesis is recommended according #1 desire of the patient. Desire of the informed patient is the most important in choose tissue or mechanical valve. If there is no contraindication to anticoagulation, the first priority for mechanical. Also, if the patient has a risk of accelerated structural valve deterioration, especially those with hyperparathyroidism or those with young age less than 40. Also, if you go to choose bioprosthetic, #1 is the desire of the patient. #2, when there is good quality anticoagulation is unlikely. If the patient is careless, cannot take anticoagulation for a long time, has another comorbidities, has a high risk of bleeding risk, has a contraindication, unwilling, like that, you will go for bioprosthetic valve. Also, bioprosthetic valve is recommended for reoperation for mechanical valve thrombosis despite good long-term anticoagulation. If the patient is already on mechanical valve and follow anticoagulation regimen good with control of INR and the same in the desired range, and then he get mechanical valve thrombosis, they prefer when redo to be by bioprosthetic valve. Also, bioprosthetic valve is considered for young women contemplating pregnancy, which is class 2A. So it is not sharp decision for the patient to go for tissue or mechanical. It is just preferable. I prefer to go for this or this. Because mostly after bioprosthetic for young women that put in mind that you're going for pregnancy, you will go for bioprosthetic valve, but after that you may need to change the valve by mechanical valve. Here they said regarding this woman, mechanical valve over excellent hemodynamic performance, long-term durability, but the need for anticoagulation increased maternal and fetal mortality and morbidity, and the risk of major events during pregnancy is much higher than bioprosthetic valve. However, bioprosthetic valve in young women is associated with high risk of structural valve deterioration, resulting in the risk of going through pregnancy with dysfunctional valve, and eventually in the inevitable need for reoperation. Do you have any comment, Dr. Ala, regarding this, or to continue?
And I have a question for Dr. Ala. Ala, you hear me?
Yes, sir.
Ala, if you have a patient with a severe mitral regurgitation with criteria for repair, is okay, but he is in atrial fibrillation, so he has an indication now for anticoagulation. His anatomy is suitable for repair. How do you go?
How old is he?
Say 40.
40. Actually, first thing, I will go to the patient and describe for him what is the advantage of mitral repair and what is the problem of mitral valve replacement. Because I believe that even in presence of atrial fibrillation and the need for anticoagulation, presence of prosthetic valve is a disease that will increase the incidence of thrombosis and the embolization, even if the patient is going on Marivan. Which I mean, if I go for mitral repair and the patient on atrial fibrillation and he will be Marivanized for life, still it's better to have a mitral valve, metallic valve in position with Marivanization. The risk of thromboembolism is higher on presence of prosthetic valve more than mitral repair in presence of atrial fibrillation. I'm a believer in mitral valve repair superiority. Mitral valve repair also, in the long run, maintain the geometry of the ventricle and the contractility. Even if after the operation by 4 or 6 months, if you have a jeopardized myocardial contractility, with time, it will maintain a good function, much more durable time, more than mitral valve replacement if you cut one or two leaflets and put your valve in place. Actually, the most important in these patients is go for left atrial rhythm surgery, like Cook's maze, or now we do now simply ablation, cryoablation. Those devices are present in Egypt. They are a little bit costly, like 10 to 15,000 more than the usual cost of the operation, but it's doable, it's easy, it can revert the patient into sinus rhythm, and if you are going to repair valve, which is favorable morphology, and revert the patient to sinus rhythm, and going to close the mitral left atrial appendage, this is a very important step. This is a very important step in any mitral valve repair or replacement, is to close the mitral, the left atrial appendage. Many surgeons are lazy to close left atrial appendage. It's a big mistake, because actually speaking, the needs for thrombus and embolization mostly in the left atrial appendage. This is the most vulnerable site for thromboembolism. So we have to close it, and closure of left atrial appendage is tricky. Some people is going to have a simple suture to close it, or 1 or 2 pies to close it, but I am now closing this mitral, this left atrial appendage over a pericardial patch. This is a technique I do. I believe that this will never open again, because when you see post-operative echo after 2 years of the operation, 50 to 60% of patients who has usual left atrial appendage closure, they have reopened left atrial appendage, because the technique of closure is not good. If the closure was meticulous and good, this place will be closed, and the higher possibility of thromboembolism will not happen from the start. To summarize this, mitral valve repair, even in the presence of atrial fibrillation, is superior than mitral valve replacement.
Can we think about at that time, Dr. Tamer, if we have a mitral valve repair in presence of atrial fibrillation, after that we can go also for NOAC instead of vitamin K antagonist?
We can now. I think NOAC are preserved only, not allowed only in mechanical, and in rheumatic mitral stenosis.
So this would be another advantage.
So it may be an optional, good option for yes.
Okay. So for this patient, we already did mitral valve replacement with mechanical valve. And as per guidelines, oral anticoagulation using vitamin K antagonist is recommended lifelong. Also, we should know that bridging using therapeutic doses of unfractionated heparin or low molecular weight heparin is recommended when vitamin K antagonists like warfarin. Treatment should be interrupted. So if you need to interrupt, you will go for bridging, whatever, to do surgery or for delivery. Addition of low dose aspirin to vitamin K antagonists should be considered in European guidelines after thromboembolism, despite adequate INR. So if thromboembolism due to inadequate INR, they did not prefer aspirin, but they prefer if there is thromboembolism after adequate INR, or in case of concomitant atherosclerotic disease like atherosclerotic coronary artery disease, which is against or change it in the American guidelines. They put it as a routine that you should give aspirin with any mechanical valve in mitral valve position. Also in the European, they added if the patient is well educated and you have a machine for testing glucometer, like glucometer, which is coagulometer, you can go for INR self-management is recommended, provided appropriate training and quality control. Or if he did it even in the lab, he can control it by himself. And I already, many literatures speaking about WhatsApp control of INR with many patients, and I started it by myself, that this will help the patient to make life easy for him. Oral anticoagulation, as you said, it is lifelong.
Before interruption. So the second key message, the use of low dose aspirin without indication as adjunct to warfarin is not recommended unless there is a risk of thromboembolism or an atherosclerotic risk. Okay.
Yeah. The Europeans.
No routine aspirin with.
This is our routine work.
I think that this is the European guidelines. I think that American guidelines states
American give it routine.
Yes, routine, even in pregnant females.
Even in pregnant, you will discuss it.
But I think that the American guidelines is better in this situation. This is my belief.
We say, if you have a patient on adequate INR without any add of aspirin, it is, they found in the European, it is better not to add more hemorrhagic complications.
Yes.
If there is no indication. Regarding tissue valve, oral anticoagulation is recommended lifelong if there is another indication for anticoagulation, as we said. But usually they give it for the first 3 months after implantation of mitral tricuspid bioprosthesis, and then they continue with low dose aspirin. Okay. Let's go for the third question. As the patient is already bought a mechanical valve and she is going for lifelong or long-term anticoagulation with warfarin, what is the target INR in this situation? 2 to 2.5, 2.5, 2.5 to 3 or 3, 3 to 3.5 or 3.5, 3.5 to 4. Is it range or fixed figure? Let's to choose, and we give 1 minute, and during that we can continue our discussion. Regarding aspirin, until answers, regarding baby aspirin, the recommendation of the American guidelines is to give it for any mitral valve, whatever. And for aortic valve replacement, if there is another risk factors like left ventricular dysfunction, for example, or atrial fibrillation. However, even during pregnancy, when you give warfarin, they recommend to add aspirin. However, in the European guidelines, they are afraid from bleeding and hemorrhagic complications, so they be referred to be restricted in case of thromboembolism or in case of atherosclerotic concomitant disease.
Dr. Hatem, till the answers for the question are coming, what is the rationale to use aspirin or low-dose aspirin in patient on warfarin without another indication for antiplatelet? What is the rationale as American guidelines recommend?
They said that it is safe. It reduces the thromboembolic complications, as they said. But I think till now there is no large or mega trials or even big trial that can give us the effect or the advantage over
clear answer. So what is the evidence?
The only study I found that done by the British RUBAC study or registry about pregnancy, that they refused to add aspirin. They said it increased incidence of hemorrhage and complications. Yes, sir.
Dr. Hatem, what is the level of evidence to use low-dose aspirin without an atherosclerotic or thrombotic risk in patients on warfarin? What's the level of evidence?
Yeah, let's go back to the slide. If we look here,
in the American, you said that American advised to use low-dose aspirin. What is the class and the level of evidence to use?
Class 1. Class 1. Evidence B.
They put it class 1. This
yes,
is
evidence B.
The point of view, it's class 1. I think a level of evidence B.
Yes,
I
sir.
will make it. It's coming in the futures, in the next slides.
Okay, we are waiting.
Okay, so most of the YouTubes are voting for C, for the option C.
2.5 to 3.
Yes.
Okay, my opinion, and maybe I'm correct, maybe they are correct, because there is no clear cut. It is gray zone. This INR. I found it is 3, and I will answer why. You know that European is somewhat make something to be not lose. You can give you choices. American are sharp. So anyway, in general, INR less than 2 is inadequate for any patient. From 2.5 to 3.5 for any mechanical valve are adequate for most newer mechanical valves, especially tri-leaflet, and especially those of Medtronic, especially those of, if we speak about on X for aortic valve, you can go for 2 only. More than 3.5 reserved only for very high risk patient, which is mitral valve with atrial fibrillation, and also if there is left ventricular dysfunction. This should be on the highest range. However, they said it clear in the European guidelines, we recommend a median INR, not a range, rather than a range, to avoid considering extreme values. If you sit from 2.5 to 3, so you will accept 2.3, which is near 2.5. Okay? You will accept 2.2 maybe, but you will accept 2.6. So they need to avoid extreme values in the target range as a valid INR. High variability in the INR is a strong independent predictor of reduced survival after valve replacement. But still, there is no evidence about all these details. But they found that in INR, very high recurrent, high INR is going with bleeding. Low INR recurrent is going with evidence of thrombosis or thromboembolism. So they put figures. If you have a prosthesis thrombogenicity is low. Prosthesis thrombogenicity is low means if it is Medtronic Hall, if it is Carbomedics, if St. Jude, which I think Dr. Ala can help us. I think most of the patient is St. Jude, right?
Yes,
or what?
Now,
Yeah.
now most of the patients are Sanjud, or even all the types are FDA approved mechanical bileaflet, so they are all low risk.
So they can consider low risk.
Yes, sir. Yes.
Maybe the best of them regarding INR is on X for aortic valve, which can go for low INR. Medium, which is other bileaflet with insufficient data. High is the old one. We still have little patients still surviving,
Yes.
like Yorkshire and tilting disc and Star Edward. However, so most of our patients can considered in the thrombogenicity low. We will go for the next point. Does they have another patient-related risk factors? Yes or no? If what is the patient-related risk factors? Either mitral valve replacement or metallic or tricuspid valve replacement, or previous thromboembolism, or atrial fibrillation, or patient without valve replacement but mitral stenosis of any degree, and atrial fibrillation, or ejection fraction less than 35. If you have one risk factor or more, you will go for this. Our patient is low risk, as we said, and she has one risk factor that is mitral valve replacement. So the preferred INR is 3. So we'll go to put it on 3. And we can accept it to be less or more in a little range. So if it is 2.8, okay, 3.2, okay, but not to be going 3.5 and more, and not to go down to less than 2.8 and 2.75 is not accepted. So we put here on 3. When you give the patient a sharp figure, he will try to keep on it. If you give him a range, he will get loose. 2.5, no problem, I am 2. 3, no problem, I am 3.5. After that, you found the patient is going for bleeding or going for thrombosis. This is the American guidelines for anticoagulation of prosthetic valves that we discussed it with just now with Dr. Tamer. They give as by this yellow, by this red arrow, vitamin K antagonist with INR goal 3. They said it clear, the same as European, but they add aspirin 75 to 100 milligram once daily as a long term, and they give it class 1, evidence B. Okay, in mitral valve. In aortic valve, with risk factors, the same. Without risk factors, you go back down to 2.5. Okay. In tissue valve, it is different to be 2.5 for any valve for the first 3 months, and then they will continue with aspirin. And in case of TAVI, they give clopidogrel and aspirin for first 6 months. And here they said for bridging with anticoagulation with unfractionated heparin or subcutaneous low molecular weight heparin. Okay. When it is interrupted vitamin K antagonist for non-cardiac procedures. Okay. Let's continue our scenario. The patient was operated for mitral valve replacement with mechanical valve with adequate anticoagulation. She is on warfarin dose 6 milligram daily with INR range 2.8 to 3.3. So she is adequate anticoagulated. After 1 year, when she felt that she is nice, she came to her cardiologist seeking advice as she is planning to get pregnant, that before she said no need. So our patient is not straightforward. And now, before 3 years without follow-up of echo, and now she came to say, I need pregnancy now, when she found herself well. And this is a common scenario. What's your advice for this patient regarding pregnancy? She must avoid pregnancy, or she should avoid pregnancy, or she may proceed pregnancy with some precautions, or she can proceed safely. Let's choose until we speak with Dr. Tamer and Dr. Ala regarding the anticoagulation after mitral valve replacement. Do you have any comment after these guidelines, Dr. Ala?
No, sir. I'm convenient with these guidelines.
About the figure of INR, do you have any suggestion when you?
No, I think that
after surgery?
Yes, I think that's 3 INR for mitral is good INR, and it should be 3, as you said, sir. We do not go for for 2.2 to 3, it should be a sharp number. Especially here in Egypt, we have to go for a sharp number. The American guidelines always put a good statement. They said, make it sharp, 3, and allow for 0.5 higher or less, but make it sharp for 3. So actually it will go finally for 2.5 to 3.5, but actually it tells the patient 3.
Okay. Dr. Haitham and Dr. Ahmed Saeed, do you have any reply?
Till now, there is two reply that she should avoid pregnancy.
Do you think to continue or to wait for another reply?
And another one is favoring that she may proceed with some precautions. So we have two answers for B and one answer for C.
Okay, let's go to think it is should avoid. You know, the guidelines is sharp in its statements. When they say must, it means class 1. When it means should, it means class 2A. When it said may, class 2B. When they said never, class 3. So here they said should avoid. That means if she got pregnant, she will have problems, but it can be. Okay. Pre-pregnancy assessment, risk assessment, and counseling is indicated in all women with known or suspected congenital or acquired cardiovascular or aortic disease. It is recommended to perform risk assessment for all women with cardiac disease, and we said this is prosthetic valve disease of a childbearing age before and after conception, using modified World Health Organization classification of maternal risk. And it is recommended in the high-risk pregnancy are treated in specialized center by multidisciplinary pregnancy cardiac heart team. Okay, let's to go for what is the position or the statement for mechanical valve in the modified WHO classification for maternal cardiovascular risk. We have class 2, which is safe, class 2 to 3, which, as we say, may proceed with some precautions, and the class 3 and 4, which is dangerous. Class 3 high risk, class 4 contraindication. Class 3 mechanical valve is considered a class 3, even if it is a nice course and well anticoagulated and everything is nice, it is high risk for pregnancy and should go for counseling. Why? The risk is significantly increased risk of maternal mortality or severe morbidity with pregnancy for mechanical valve. And also the maternal cardiac complications or event rate is 19 to 27%. About quarter of patients got problems. Also, counseling with expert counseling is required. Expert center for pregnancy and cardiac disease if she insists to continue pregnancy or to get pregnant, with bi-monthly follow-up every 2 weeks and expert center for delivery. So in women with mechanical valve, pregnancy is associated with a very high risk of complications. In the RUBAC registry, which is the most important registry for pregnancy and cardiovascular disease and pregnancy and the mechanical valve, the chance of event-free pregnancy with live birth only 58 for women with mechanical valve. That means that women with mechanical valve and the nice course and everything is nice, only 58% will go for nice delivery and the nice outcome of pregnancy, and about 42% will get complications, compared with 79, about 80% for women with tissue valve or women with heart disease but without valve prosthesis. Okay, recent study from UK, another study reported favorable outcome for mother and baby only in 28. That means it is very important that to take decision to get pregnant or not. The main risk are related to the need for anticoagulation therapy, valve thrombosis, hemorrhagic complications, and if there is another factors like ventricular dysfunction or valvular dysfunction. So it is high risk pregnancy or even up to need for counseling. Okay, and long-term prognosis for fertility, miscarriage, and should go for counseling. Estimated maternal risk and the fetal risk should be discussed with the patient. If we go for the predictors of maternal cardiovascular events, one of them is the NIHA class and, but the most important here is the mechanical valve prosthesis alone is a predictor of maternal event. And even it is a predictor of neonatal event. So the patient did not listen to the counseling team and get pregnant. She take her decision, I will get pregnant, despite she was advised and she was accepting before choose of mechanical valve. Tamam? Okay. Dr. Mohammed Medhat have a comment here before we continue. Yes.
Thank you, Dr. Hatem. This make us go back for your first two questions. Must we perform mitral valve replacement for this female patient with a mechanical valve with only one child in a which is an Egyptian female in this community that needs to have more children, or we will wait for medical treatment till she came pregnant for another child, or we will put a bioprosthetic valve?
I think,
Dr. Hatem, can I have a comment here, please?
Yes.
Hatem, if we go back a slide, you will see that patient with prosthetic valves, mechanical, 52% may go. Without valve replacement, the risk go, yes, here is the second one, and zero pack registry. We see that women with a mechanical valve, the chance is 58%. And if this bioprosthesis, it will be 79. If no valve disease, it will be like a bioprosthesis. So we still have a risk, and we should go for replacement here in this woman, because we have a high risk even without a valve replacement.
I think if the patient is asymptomatic with favorable left ventricular dimensions, I will ask her to until she get pregnant, and at that time I will take decision out of the guidelines to continue follow up until she get another baby maybe. But the problem
you may face a reduction in the ejection fraction, and we'll go to the gray zone.
Yes,
yes,
I want to
yes, and this is a gray zone. However, the patient, if asymptomatic, we still have a chance. But the patient, even if asymptomatic, its end systolic dimension is high. Another point, if the patient is already NIHA class 3, so it is difficult to put her in face of pregnancy. If you go for this slide, you will find that NIHA class 3 or 4 is one of the predictor of maternal cardiovascular events with mortality up to 40%.
Yes, can I make a comment?
Ask her to get pregnant without any intervention, whatever repair or tissue replacement or mechanical. Yes.
So before your comment, dear Ala, can I rephrase the question of Dr. Mohammed Medhat in a more direct way? Should we consider the local social parameters or the local social conditions in our country or in any other country to contribute in our decision along with the guidelines if the short-term outcome is the same? So should we include this social consideration into our decision or not?
Yes,
we haven't done evidence to go with this recommendation. So it may be optional, but no evidence with the guidelines.
I think that this patient should perform a mitral valve replacement with tissue valve. She was on sinus rhythm, and when she put a tissue valve, she will have a good post-operative condition for many years, up to 10 years, without need for a re-intervention. This bridging time will allow her to have more kids if she likes this. And after this, she may go for mitral valve replacement with a mechanical valve. So actually, when I have a female patient, young, with no offsprings or one offspring, and I know that with the Egyptian society, she will have she will try to have a new baby. If she refused or denied this at the start, after time she will have a new baby. So if she is in sinus rhythm, there is no need for anticoagulation. So I will put here a tissue valve, and after bridging the childbearing period, I will go for mitral valve replacement with a mechanical valve.
Okay, that's true. And let's go to ask her that she already came to inform her cardiologist and the obstetricians that she is pregnant and the need for close follow-up, as I said. Regarding vitamin K antagonist, what is your advice during pregnancy? Continue throughout pregnancy, continue
Seems like Dr. Khatem have stopped. Or what?
Yes,
I'm sorry, I got out and I came back.
no problem, Dr. Hatem. Please reshare your slides, please.
Okay, again, harder.
So till Dr. Hatem shares his slides, so we are now going to the delicate situation of pregnancy with the prosthetic heart valve. And we now will see the question of anticoagulation during pregnancy.
Yeah, as you said, either to continue vitamin K antagonist and don't listen from A to Z, continue but shift last 2 weeks before delivery, or shift in the first trimester and then go back to vitamin K and then shift to parenteral before delivery, or shift from the start to parenteral anticoagulation all over pregnancy. What you will choose for this specific patient?
Let's remind the viewers with the dose of warfarin she is using, Dr. Hatem.
She is using 6 milligram with target INR from 2.8 to 3.3.
Thank you, Dr. Hatem.
Dr. Mohammed Medhat, as we discussed until the answer, that this patient, what's preferred for her, I think if we consider the community and the education level, the patient here, the most problematic point of view is the lack of follow-up. And if you think about the patient to do tissue valve with lack of follow-up, they may come to you with a difficult situation. It is preferred, yes, I know, but before, maybe before 10 years, it was difficult to do mitral valve operation and then with planning to do redo. Most of patients say, no, solve it, put mechanical valve. You need to get pregnant. So no. It is preferred for me not to do operation twice. After she feel okay, she change her mind. This is the point of view. However, if we go for strict, follows the guidelines, if it is possible for her to do repair, we will go. If not, to go for tissue valve, and after pregnancy and delivery with close follow-up of echocardiography for another two childs, I think they can go for mechanical valve. This is the best situation. However, here, this is the commonest situation or the commonest scenario happen in our country, that most of patients going and doing mechanical valve, and after that, think again about another baby. And I found it not only for one baby. Female have 3 children, and some of them may be aged about 20 years old, 15 years old. And after 7 or 6 years of the last child coming, ask for pregnancy, which is 40 years old, and ejection fraction around 52%, and she has valve and aortic, and ask for pregnancy. So this is a common situation that we found.
Dr. Hatem, we have the answers on YouTube. Most of the answers are going for C, the option C, and very few are going for the option D.
Sorry. It is I replaced it during most of Dr. Tamer.
Do you think the level of dose of marijuana over 5 milligram to get INR in the target will affect your decision or not? She needs more than 55 milligram to go the target INR. It will take part in your decision for anticoagulation.
Here, the answer?
Yes, I ask.
Yes, sure. Sure, yeah, that's what we want to say. I'm sorry I shifted it. Yani parenteral, the correct answer is to shift from week 6 to week 12. Most of patients, she knows that she is pregnant when she gets missed the period. Usually she is in week 6 when she came to her doctor. So ask her from week 6 to week 12 to shift to parenteral anticoagulation. Then after 12 weeks, she will go back to warfarin until before delivery by 2 weeks. She again shift to parenteral. This is the best situation if she is more than 5 milligram warfarin. But if she is less than 5 milligram, I will go for B, which is continue her vitamin K antagonist, and before delivery by 2 weeks to shift to parenteral. Let's to see what is the guidelines say. In the European guidelines, they said women with mechanical valve and a high dose of vitamin K antagonist with warfarin more than 5 milligram per day, or phenobarbital more 3, or acinocumarol more than 2, which is not available in our country, but usually warfarin more than 5, who contemplates pregnancy and the pregnancy counseling, she will continue vitamin K antagonist again, antagonist until pregnancy. Yani if she go for counseling and she insisted to get pregnant, they said there, okay, continue your vitamin K antagonist, and once you get pregnant, come to us. Once you found missed period and you did pregnancy test and it is positive, come to us. At that time, we will go for, in the first trimester, okay, they go for continue vitamin K, monitor INR at least twice per week. This is not the main situation. I prefer to be in hospital, and should be in hospital when you change from warfarin to parenteral, or from parenteral to warfarin, to be in hospital, not at home, which is preferred. And the class 2B, class 2A, to give in hospital, change to intravenous, not subcutaneous, intravenous unfractionated heparin with activated partial thromboplastin time equal or more than double the control, okay? Or to give in hospital low molecular weight heparin 1 milligram per kg twice per day with close monitoring, okay? And at the time, you should do follow-up with level of activated factor 10. Then, this is in the first trimester. Then, they have in the guidelines of the European something which is strange little, that they say you can continue vitamin K antagonist and monitor INR at least twice weekly, okay, or at least every 2 weeks, and then in the second trimester you will continue and monitor INR at least 2 weekly. However, in the American guidelines, they said it clear, no, more than 5, go for unfractionated heparin or low molecular weight heparin. And I suggest this from my point of view, the same, which is yellow, class 2A. In hospital, change from low molecular weight heparin or unfractionated heparin back to vitamin K antagonist should be in hospital when target INR monitor reach to the target. And what I mean, the patient will start warfarin again in the second trimester after 12 weeks of pregnancy, while you still on heparin or low molecular weight or unfractionated until she reach to the target INR. Then you will follow up INR at least every 2 weeks, which is every visit, okay? And there is another line or another opinion, which is class 2B, that you can continue low molecular weight heparin twice daily with close monitoring of the activated factor 10. At the week 36, when she reaches 36 weeks, you will go for in-hospital change from VKA or warfarin to unfractionated heparin with activated partial thromboplastin time more than 2, or low molecular weight heparin by the same method. But it is preferred to be unfractionated heparin before, if you are planning for delivery 36 hours before planned delivery. So if it is planned delivery, what I mean, if it is the third baby with prior to cesarean section, you will go earlier by 2 weeks, so you know the exact time of delivery, which is not, it is elective cesarean section. But if it is not planned delivery, you should earlier go for unfractionated heparin. Okay? Stop unfractionated heparin 4 to 6 hours before delivery. And if for unfortunately the patient on low molecular weight heparin and she will go for delivery, you should stop for 12 hours. After delivery, you restart 4 to 6 hours after delivery intravenous unfractionated heparin if there is no bleeding. This is the first point that's suitable for our patient, which is on what's called warfarin 6 milligram. Okay. Second point, if the patient warfarin less than 5, why they said why to go for her for bridging? Continue vitamin K antagonist and monitor INR at least every 2 weeks, and continue until 36 weeks, and then shift for unfractionated heparin better until she got delivery, or shift to low molecular weight until 36 hours before delivery, shift for unfractionated heparin if it is planned. Some people say no, I will go for the old strategy that I should go for in the first trimester to go for low molecular weight or unfractionated, and then again after 12 weeks I will go for warfarin again. Anyway, the best strategy for this patient, as she is on high dose of warfarin, is to shift to low molecular weight heparin, okay, and after that, which is more practical and more valued and more easy, especially in our country. And once she go in the second trimester after 12 weeks, we will restart in hospital. She will be admitted and start warfarin until she go for target INR, continue warfarin, and advise her at 36 weeks she come to be replaced again by unfractionated heparin and stay in hospital till delivery, or low molecular weight heparin and come to before delivery by 1.5 days to change it to unfractionated heparin that stopped 4 hours or 6 hours before delivery and restarted after delivery by 4 to 6 hours. Okay, if we go for American style, they said that patient pregnant with mechanical valve and on therapeutic anticoagulation with frequent monitoring and the baseline warfarin less than or equal to 5, I will continue warfarin at the same like European, or you can go for low molecular weight heparin or unfractionated heparin. And if it is more than 5, you have no choice except that you will go for in the first trimester for low molecular weight or unfractionated. They did not give you another choice. But for the second and third trimester, they prefer that warfarin you should add aspirin, which is not present in the European guidelines, and discontinue warfarin and discontinue and those adjusted continuous infusion of heparin intravenous with activated partial thromboplastin time at least to be doubled. So, the most debatable that we think, okay, I will give low molecular weight. How much dose? It is 1 milligram per kg body weight for enoxaparin and 100 international unit per kg for deltaparin, twice per day subcutaneously. And the dose should be adjusted daily according to the peak or peak and the trough. What is the difference? Peak means at the peak time 4 to 6 hours after the dose. You give 4 hours after the dose, which reach to the peak. Trough means you check the activated factor 10 just before the next dose. And the routine addition of acetyl salicylic acid is not recommended in the European guidelines. And I think if you give low molecular weight, no need to give aspirin. You will give, otherwise you will, because this is high dose, which is mainly therapeutic dose, not prophylactic dose. When you give unfractionated heparin, okay, after a stable activated partial thromboplastin time achieved, it should be monitored weekly. And so you will do every day activated partial thromboplastin time. Once it is doubled, خلاص, you will do it once weekly monitored, and the patient on infusion, which is prolongation equal to or more than 2 times of control. And during second or third trimester, go back for vitamin K antagonist. Right. Why not to be on, as we said, on parenteral anticoagulation all over the pregnancy? We should to say that the compliance of prior anticoagulation is better. The patient already on warfarin and she is happy, and if it is less than 5 or 5, she can continue. This will be easy for compliance. The mother should understand whatever anticoagulation regimen should, that she should go for strict compliance for successful outcome. And the continuation of vitamin K throughout pregnancy should be considered when dose is low, because with low risk of embryopathy and fetopathy. Embryopathy means about limb or bone deformities and nasal deformities. Less than 2%. And fetal loss less than 20%, which is very good in comparison with other regimen. Vitamin K antagonists are the most effective regimen to prevent the prosthetic valve thrombosis. There is scarce evidence about unfractionated heparin in the first trimester or throughout pregnancy because of high risk of valve thrombosis up to 33%, with additional risk of thrombocytopenia or osteoporosis. So only if I use it, it is better to, in the first trimester and 2 weeks before delivery. Low molecular weight also has a risk of valve thrombosis, so they are using it in high dose 1 milligram per kg twice per day. And because the dose requirement is markedly increases due to its renal clearance, we should do, which is, if not available, it is class 3 to use it in pregnancy. Monitoring of activated factor 10 level with dose adjustment, this to reduce the risk of bleeding or thrombosis. Low molecular weight heparin throughout pregnancy with activated factor 10 monitoring and dose adjustment according to the peak level carries the least value thrombosis of 4.4, which is near to that of vitamin K antagonist. So molecular weight heparin is possibly superior to unfractionated and prevent valve thrombosis, and it will be good and nice if you have a monitoring of anti-activated factor 10. During, what about delivery? Number one, planned delivery is necessary. For this patient, I should inform her she should be close monitoring. We should decide the time of delivery with its range for 2 weeks. Vaginal delivery requires a prior switch to intravenous heparin. Never to do vaginal delivery while the patient is still on oral anticoagulation like warfarin, and or even stopped it less than 2 weeks because of the risk of intracranial hemorrhage for the fetus. The use of epidural anesthesia is difficult. It requires prolonged interruption of anticoagulation therapy, which may contraindicate its use in women with mechanical valve. So a planned cesarean section may therefore be considered as an alternative, especially in patients with high risk of valve thrombosis. So if I have a patient that use very high doses of warfarin and I will shift to heparin, it is better to give her a planned cesarean section to keep the time without vitamin K as short as possible. Cesarean section should be performed if labor onset occurs while the patient is still on vitamin K antagonist or stopped less than 2 weeks. The indication of cesarean section, we know that either obstetric indication not on our job, or maybe another indications in cardiology. What's important for us here is unbooked patient that coming presented in labor while she is still on oral anticoagulation to avoid intracranial hemorrhage. Still vaginal delivery advised for most of women and associated with less blood loss, less risk of infection, and less risk of venous thrombosis and embolism. But the patient should be on adequate intravenous unfractionated heparin that stopped about 4 to 6 hours before delivery. And this is the final guidelines and the decision regarding delivery and pregnancy. It is recommended that valve prosthesis for a woman contemplating pregnancy is chosen in consultation with pregnancy team. It is recommended to manage pregnancy in women with mechanical valve in a center with a pregnancy heart team. If delivery starts while the patient on vitamin K antagonist or less than 2 weeks after discontinuation, cesarean section is recommended. And it is recommended to discontinue vitamin K and start adjusted dose of unfractionated heparin or low molecular weight heparin at 36 weeks of gestation.
Sorry for interruption, sir. Dr. Hatem, the time is going.
Okay,
so
I will go. I'm about to finish.
The target points.
About to finish. The most important now is low molecular weight heparin is not recommended when weekly anti-activated factor 10 level monitoring and dose adjustment is not available. So if it is not available, either to go for intravenous heparin or to avoid pregnancy. Okay, this was slides regarding bridging of anticoagulation. If it is not pregnancy, if going for surgery or something like that, it is by the same way. You stop vitamin K and start low molecular or unfractionated, and start unfractionated heparin 1 day before surgery. Stop unfractionated 6 hours before surgery. Restart unfractionated 12 hours to 24 hours after surgery or intervention if there is no bleeding risk. After that, you can add on heparin, add on warfarin, and then start to go for the both together hyper unfractionated or low molecular weight together with warfarin until you reach to the target INR. After that, you will stop the parenteral. The patient will continue our last slides of the scenario. Last point, the patient is doing well after vaginal delivery and resumed oral anticoagulation with achievement of target INR. However, after 4 months of delivery, patient developed some body ecchymotic patches with epistaxis and her INR was 6. How to manage? Stop warfarin and follow-up. Stop warfarin with local ENT management. Stop warfarin and give vitamin K 1 to 2 milligram oral. Stop warfarin and start intravenous fresh frozen plasma. Start warfarin and give vitamin K 10 milligram intravenous. This to choose rapidly.
You can proceed with answer, please. For time, you can proceed with answer and explanation.
Okay. Let's go for answer. You can have the choice either to stop warfarin. Yani if there is no bleeding at all, stop warfarin and follow up of INR daily until it came down. But here you have epistaxis, and epistaxis is not a severe bleeding, so you can ask for local ENT management. If it's stopped, okay. If not, you can give very low dose vitamin K oral 1 to 2 milligram. This is called the prosthetic valve dysfunction. Anything affecting hemodynamics or durability or thrombogenicity is considered prosthetic valve dysfunction. And one of them is anticoagulation related hemorrhage. And the risk of bleeding starts when INR exceeds 4.5 and increase exponentially if above 6. Now we have a patient with 6 that require rapid reversal of anticoagulation because of the risk of subsequent bleeding. And put in your mind that vitamin K will not stop the expectation of hemorrhage to happen. The absence of bleeding management depends on INR, so and the half-life of vitamin K. So it is possible to stop only vitamin K antagonist and allow INR to go down. Or if you are afraid from this epistaxis, you can give vitamin K only 2 milligram. Immediate reversal using intravenous prothrombin complex concentrate and vitamin K or fresh frozen plasma is required for severe bleeding, defined as not amenable for local control or life-threatening or important organ function or intracranial bleeding, like, for example, hemoptysis, hematemesis, and intracranial hemorrhage. Anyway, in short, if you give oral vitamin K, it will take around 24 hours to give its maximum effect. If you get it intravenous, from 8 to 12 hours. But the only ones that act immediately to stop bleeding and give effect is fresh frozen plasma, okay, and its duration of action for 24 hours, and plasma and prothrombin concentrate, okay. The last slide that you say, bleeding is not infrequent problem in patients with mechanical prosthetic valve, as they are thrombogenic, requiring chronic anticoagulation. And administration of fresh frozen plasma or prothrombin complex concentrate is reasonable for patients with mechanical valve and uncontrollable bleeding who required reversal. Thank you.
Thank you very much, Professor Hatem. I think we have we take a long time, so we want to proceed to the our next speaker, Professor Ahmed.
Good evening, everybody. I really find it very difficult to talk after this heavy and concise lecture about all the complications and management of the prosthetic valve. Please allow me to share my screen, please.
So Dr. Hatem, stop sharing your slides. Thank you.
Okay.
So I have two cases. It's a case-based discussion about the prosthetic valves and dysfunction. I will start by case number one, starting by the medical history. She's a 28-year-old unmarried female. She's known to have rheumatic heart disease, and she had severe MS and has more than moderate MR. So she went for mitral valve replacement for the first time 7 years ago. And 4 years later, she developed pulmonary edema from large prosthetic valve thrombosis, and upon which she had repeated sternotomy and redo of the mitral valve replacement 4 years ago. But unfortunately, she was not compliant to warfarin after the second time of valve replacement. And she presented to me by complaining of 3 days of dyspnea, orthopnea, and palpitation, and her latest INR was 1.4. And during her clinical examination, her blood pressure was 110/60. She was tachycardic, but in sinus rhythm, heart rate was 120 beat per minute. And on the auscultating of the heart, she had a diastolic murmur at the apex with non-audible prosthetic valve click, and the chest showing fine bilateral basal cramps. So the first thing that came to your mind that this valve is dysfunctional. So immediately she has been taken to the echo lab, and the transthoracic echocardiography was done. As you can see here, there's big turbulence over the prosthetic mitral valve here. And by Doppler interrogation, you can see here that the mean gradient and peak gradient are extensively elevated. So this goes with valve obstruction. And she had a pulmonary hypertension, and also the pressure half time of the valve is increased. So a small learning point here: when to suspect a prosthetic valve obstruction with transthoracic echocardiography. When you have a high peak E velocity, more than 1.9, then you have a valve dysfunction. If it's crossed 2.4, then you have a definite valve dysfunction. Then you look at the pressure half time for this. If the pressure half time is less than 150 milliseconds or more than 150 milliseconds, so if it is more than 150 milliseconds, then you have an obstruction. So, and this is example of the peak A wave of both prosthetic valve. This is on the left side, this is a normal valve, and on the right side, this is the abnormal valve. And the causes of the increased velocity across the peak E velocity of the prosthetic valve is the hyperdynamic state, tachycardia, small valve size, stenosis, or regurgitation. So you should be aware that there's some other causes that can cause increased gradient across the valve, not just the obstruction. So let's go back to our patient. After the transthoracic echocardiography, we take the patient to the transesophageal echocardiography. You can see here from these images that there's one leaflet only is moving and the other one is not moving. So this is a stuck mitral valve. And you can see here the other one is occluded by a thrombus. This is a more zoomed image on the valve. And you can see there is a thrombus on the image on the right side. its area was 0.9 centimeters square, so it's a relatively big thrombus. So we have here all the echocardiographic sign of prosthetic valve obstruction, reduced lifted mobility, presence of thrombus by 2D, abnormal transprosthetic flow, central prosthetic regurgitation, elevated transprosthetic gradient, and reduced effective prosthetic area. So we are dealing with a new.
Ahmed, can we stop here for a moment, please,
Yeah.
and take our surgeon decision, Dr. Alaa?
Yeah.
What's your opinion?
Excuse me?
Yes. Okay. What's your opinion after showing the transthoracic and transesophageal echo of this young woman?
Yes, she has mostly obstruction, valve obstruction, thrombosis.
Yes.
So for surgery directly?
Yeah, what?
To go search for surgery directly, what to do?
According to her general condition, according to the thrombus size, I will decide.
The discussion about this and decision of the patient will be discussed later.
Yes, the exact thrombus size. I want to know how
Dr. Ahmed, there is no chance to do for her 3-dimensional?
At this time, it was not possible. The machine that was available for the transesophageal didn't have the 3D possibility.
Yes, okay.
Okay.
Okay, continue, Ahmed.
So, what to do next? As Dr. Alaa said, we have to assess the patient on the clinical status of the patient. What is the New York Heart Association class in this patient? And to see the size of the leaflet. So if you have a critically ill patient with an EHA 4 class, then you can do a rescue fibrinolysis if far from surgical center, if you don't have immediate surgery available at the place. And if the patient is more stable with an EHA class 1 to 3, then you do transesophageal echocardiography. If you have a large thrombus, more than 0.8 centimeters square, you can go for surgery. If you have a small thrombus, you can go either with the surgery or fibrinolysis. And this is the hierarchy, how to go with left-sided prosthetic valve thrombosis. If this is obstructive, like our case, and this a prohibitive surgical risk or surgical treatment is not available, then you can see the clot burden. If it is large, you can go for surgery. If it is not large, you can go with thrombolytic therapy. So, what we did with this patient? Let's remember that this patient had previous mitral valve replacement 7 years and at 4 years ago. So this patient had twice cracking her chest before. And also she is in decompensated heart failure. His NEHA class is around 3. So this patient is a very high risk for a third chest cracking with high STS score. And the TEE images are consistent with the thrombus. We had a shared decision with the cardiothoracic team at our infirmity, and we decided to proceed with the thrombolytic therapy. And streptokinase was given, and also a small dose of beta blocker and aviodiuretics was given. I would like to hear from you. Do you agree to this decision or not?
For me, it is reasonable to for this decision, but about the small dose of beta blocker may be controversial. But the chance to give streptokinase may be optional in this special situation and may be successful. We reserve the surgery as a backup if failed.
Great. Other opinions?
Yeah, for me, from the start when she came first time and she was uncontrolled INR and coagulation, so I think at that time, I don't know the situation, but I think at that time, if she given thrombolytic therapy and after that good control of anticoagulation, it will be better to go for surgery. Anyway, she did surgery since 4 years and came to you. I think her problem is that she is not compliant with anticoagulation and she is not follow it regularly. Here you have one of two decisions, either to give thrombolytic therapy if she is NEHA class 4, and if she is NEHA class 2 or 3 and can wait, we can start only anticoagulation with unfractionated heparin infusion and wait if she is improving. If she is not improved, I will go for thrombolytic therapy. So maybe if it is a small thrombus or not or moderate, and the patient is stable, we can go for a start anticoagulation only, and maybe proper anticoagulation will solve the problem.
Yeah.
Anyway, if you found the patient is uncontrolled and not stable, and you start thrombolytic, this is a good decision, especially if you don't have backup urgent surgery, or the surgeons found it will take long time until to deal with these adhesions and to redo for the third time. But I think the best management for her is to shift for tissue valve. Oh, this is my opinion, Dr.
I want to say something. Yes.
Yeah.
Actually speaking, when you revise the guidelines, almost always reoperation is the first option, class 1 indication in these cases. We can reserve thrombolytic therapy as a class 2A in patients with small thrombus less than 0.8 and very high risk for surgery. Actually, reoperation now is not that risky, even the third or fourth reoperation with expert surgeons. What I need to say is that if I have this patient in a good clinical condition, she can be nicely prepared and the preparation of blood products and the fresh blood, we can go for surgery. And I think that if this patient is accustomed to thrombosis with every time after mitral valve surgery, I agree that may have a good chance if she is receiving a tissue valve. Tissue valve on those patients, according to guidelines with repeated thromboembolism, tissue valve is a valid option, a good option. So if this patient was in a good clinical shape, I may go for reoperation with a tissue valve.
Thank you, Dr.
Another point,
okay.
Dr. Ahmed, another point that when you give thrombolytic therapy, you have around 15%, maybe up to 20% possibility of embolic complications.
Yes.
That will be discussed later in the lecture. Okay, so I'm talking about if we can look at this patient from a straightforward point, you can say that this patient should go for surgery. Okay, but there are some factors that you have to tailor your decision, and we will see how the scenario will go later on with our patients. Okay, so the thrombolytic therapy, an expedited flow was given to the patient, and let's see after the thrombolytic therapy, the mean gradient was dropped to 8 mm mercury by the transthoracic echocardiography, and TEE was repeated again after the thrombolytic therapy. You can see here that both leaflets now are moving freely. There is a small remnants of the thrombi around the valve, but not obstructing the flow, and the transgradient is now within the normal range for the prosthetic valve. As you can see here with the zoomed image, that both leaflets are freely mobile with small, very small remnants of the thrombus around the leaflets. So let's discuss what happened with this patient. We can say that the acute prosthetic valve thrombosis is a serious complication of the prosthetic valve. It happens in 0.1 to 6% per patient per year for left-sided valves, and the mortality is high. And the obstruction of a mechanical prosthesis requires aggressive treatment, either surgery or fibrinolysis, as anticoagulation treatment will usually be insufficient. Especially if there is significant obstruction, like one of the leaflets is not moving, it's not just a thrombus that's obstructing the flow, it's one of the leaflets is not working. So here, the choice of optimizing the INR or giving a heparin is not an option here. Because of the lack of randomized studies, there are few recommendations in the literature concerning the prosthetic valve management. Always we rely on level 2 recommendation when available because of the lack of randomized trials. So always there is a decision when you have a patient with prosthetic valve thrombosis, either to go with surgery or give thrombolytics. So let's talk about the surgery arm. So it's according to the American College of Cardiology and the American Heart Association guidelines, surgery is the preferred treatment for left-sided prosthetic valve thrombosis, and recent advances in surgeries, anesthesia, and perioperative care, as Dr. Ala had mentioned, significantly improve the prognosis with a mortality of 4% for the patient with NIHA class 1 to 3 and 17.5 for patient with NIHA 4. And you can go with either with valve replacement, you can put either a bioprosthetic or in case of recurrent thrombosis. So you may put a metallic valve or you may have a prosthetic valve due to recurrent thrombosis as we have with this patient. Let's go with the other arm, the fibrinolysis. It's efficacious in 82% of cases in dissolving the thrombus that lies on the valve. But it comes with a very high price. It's associated with 10% mortality rate and 12.5 rate of systemic emboli. That's the main hindrance of using fibrinolysis in this patient. It's not because it's not effective, it's because of the systemic embolization of the dissolved thrombus from the valves of the left side. And this high complication rate has relegated fibrinolysis to second-line therapy, reserved mainly for patients with contraindication to surgery. Also, fibrinolysis should be reserved for patients with poor functional class, NIHA class 3 or 4, with high surgical risk or contraindication to surgery. As we can say here that our patient is a NIHA class 3 with previous surgery, so an STS score is a little bit high. It can also be considered in patients with good functional class, NIHA 1 or 2, and a small thrombus after failure of heparin therapy. So, how to give the fibrinolysis in a patient with prosthetic valve thrombosis? You have two protocols. If your patient is hemodynamically unstable, this is called a rescue fibrinolysis. So you can give TPA 10 milligrams bolus followed by 90 milligram in 90 minutes, or you can give streptokinase that's available in our country now. You can give 1.5 million units in 60 minutes without heparin. If your patient is hemodynamically stable, you can give a much longer protocol, is often preferred, using either streptokinase 500,000 international unit in 20 minutes, followed by 1,500,000 units over 10 hours. That can be repeated for another 10 hours to a maximum of 24 hours. Or you can give TPA 10 milligram bolus followed by 50 milligrams during the first hour, 20 milligrams during the second hour, and 20 milligrams during the third hour. So after you give thrombolytic therapy, you can judge the efficacy of the thrombolytic therapy. Is it full? Like our patient, you have hemodynamic normalization and normalization of transprosthetic valve gradients and valve area by transthoracic and normal mobility of valve leaflet on fluoroscopy or transesophageal echocardiography. Or you may have partial efficacy, like significant symptomatic improvement without complete recovery of disc or leaflet motion. Or you may have failure with no clinical improvement that included death complications like major bleeding or systemic embolization. So we are dealing now with a full success or full efficacy of thrombolytic therapy in a prosthetic valve thrombosis. So the treatment of left-sided prosthetic valve is influenced by the clinical status, as we had said, the hemodynamics, the New York Heart Association class, the thrombus size, and the presence of obstruction. The mobile or larger thrombi more than 0.8 centimeters square are usually treated surgery. The treatment of left-sided prosthetic valve thrombosis is influenced by clinically ill patients, obstructive pulmonary valve thrombosis with a small thrombus, and non-obstructive pulmonary valve thrombosis with a small thrombus less than 5 millimeters can be treated by fibrinolytic therapy. So the major risk factors for prosthetic valve thrombosis are inadequate anticoagulation, and the mitral location has higher risk for thrombosis compared to the aortic valve position. And the imaging modalities to detect this is the transthoracic echocardiography, transesophageal echocardiography, or using the cine fluoroscopy. So let's go back to our patient. So what went wrong with this patient? I think we have to go back to the beginning of the complication. This patient was not compliant with the warfarin whatsoever, even for the first valve or for the second valve. So the patient should be asked about if she's going to be compliant to warfarin therapy before choice of the valve or not. This is very important in the counseling prior to surgery. So asking and confirming about the planned patient compliance to warfarin is very important before choosing metallic prosthetic valve as the choice. And the proper counseling with the patient and relative is important before choosing the type of the valve. And we can see here from the guidelines, we can see that bioprosthesis is recommended when good quality anticoagulation is unlikely as this patient. So from the start, we may select the bioprosthesis if we have discussed, take our time and discuss with this patient if she will be compliant on anticoagulation or not. So my conclusion from this case, that acute prosthetic valve thrombosis need urgent intervention. Surgery is the preferred intervention for left-sided prosthetic valve thrombosis. In our particular patient, the decision was shared with the cardiothoracic surgery team to use thrombolytic therapy. The attempt was successful and avoided repeated sternotomy in this high-risk patient. And thank you for your time.
Thanks, Dr. Ahmed, for this elegant presentation. And it gave us a new message that we should work in a team between the cardiology and the cardiac surgeon and to take a decision. And this is an option of thrombolytic survey in some situation like that. Even surgery is the first option, but we have a good option here with regarding the site and the size of thrombus and the clinical condition of the patient.
I have one comment only, Dr. Tamer. If that regarding this patient, while he's admitted and you are planning for thrombolytic therapy, we will check his INR. If his INR is adequate, yeah, that means that he, despite he's adequately controlled by anticoagulation, he got a thrombus. This is absolute indication to go for valve replacement.
Yes.
And here we will choose tissue valve. If the patient is not controlled and INR is inadequate, this means the patient is not controlled and maybe it's his problem. And after thrombolytic therapy and after he get stabilized and started to be on unfractionated heparin infusion, we'll discuss with him, shall you go regular anticoagulation? And that time, if yes, I think we should add aspirin to his management, his warfarin. And if it is difficult or we feel that it is difficult, we will send him to proceed for surgery. And by the way, after thrombolytic therapy, the incidence of rethrombosis is about 15% to occur again. And this is the second time, so I think it should go for surgery, but maybe here thrombolytic therapy give us a chance to go for elective, not emergency.
Yes.
Okay.
We are planned for this patient to continue on a proper, we make like a consultation with their family to make her stuck to the anticoagulation for the coming 6 months, and we follow up her situation. If the INR is controlled and the valve is doing fine, she will continue with this valve. If she was not compliant or any complication is developed, the patient will be referred for surgery again. And until now, this case was done like 1 year ago, and she's doing fine right now, and her family is following up with her, and she's doing fine.
Okay.
Okay, could we proceed for the next case, please?
Okay.
Dr. Mohammed Medhat?
No, Dr. Hatem. Dr.
No,
Ahmed has
a second case.
Dr. Ahmed still have another case?
Yes.
Okay.
Yeah.
Proceed, Ahmed. Okay.
Okay.
Your slides. Okay.
Is the slide appear on the screen now?
Yes.
Okay. So my second case is a 84-year-old male. He's a status post coronary artery bypass graft and mitral valve repair 3 years ago. He is compliant to medical treatment. He came complaining of exertional dyspnea without definite chest pain. The patient had echocardiography 2 months after surgery and showed the normal left ventricular dimensions. His ejection fraction was around 45%, with akinesia of the mid and basal inferior and infralateral walls, with a competent mitral valve repair with a ring, apart from trace MR, with no further echocardiographic studies have done since then. He done the echocardiography after the surgery 3 years ago, and he didn't do any echocardiographies thereafter, and he came complaining of exertional dyspnea. On examination, his blood pressure is 110/70 millimeter mercury, and his heart rate is 84 beats per minute and regular. His heart auscultation revealed preserved first heart sound with an accentuated second heart sound, and the pan-systolic murmur radiating to the axilla, going with mitral regurgitation, with mildly shifted apex outward and downward. His chest shown fine bilateral basal crepits and mild bilateral pitting edema. So there is a new mitral regurgitation that was not present previously. So the patient was taken to the echocardiography lab for echocardiographic assessment, and transthoracic echocardiography revealed the following. Let's ask a question. What is the echo density identified by the arrow here? We have some choices.
So,
is it an aortic prosthetic reverberation artifact? Is it aneurysm of the interatrial septum? It's a biventricular pacing lead. It's an Alfieri stitch or a dehiscent mitral ring.
So thank you, Ahmed. This is a very nice imaging. This is a shadow of a prosthetic material, and in the presence of and with a history of a previous mitral valve repair. This is not commonly seen, but this is maybe a dehiscence of the mitral ring.
Yeah, I agree with you, Dr. Karim. This is a dehiscent mitral valve ring. Let's see how the color appear on this. So you have a significant mitral regurgitation across the dehiscent valve and the valve itself. The left ventricle is now a little bit dilated and systolic function is a little bit impaired, which is not the case after he done the surgery. His left ventricle was still in the normal size. And here is the fourth chamber view. You can see here he still has segmental motion abnormalities and the ejection fraction around 40% with severe mitral regurg from the detached or dehiscent mitral valve repair ring. And this is his ejection fraction using the biplan method. His ejection fraction is now 40% with a voluminous ventricle. You can see the end diastolic volume is very big. So he has a dilated ventricle right now. And also he started to develop pulmonary hypertension. Okay, so this is a case of a repair ring that's seen with partial detachment at the aortomitral curtain with a grade 4 mitral regurgitation. I have to say that this is not the common place for the detachment of the ring. The common place for the detachment is from the posterior ring, not from the aortomitral ring or from the anterior leaflet. This is a strange place for detachment. And that's it raised us to ask, what's the cause of this detachment? We asked a patient meticulously about any history of fever, but he denied he had developed any fever before. But for confirmation, we did a transesophageal echocardiography with him, confirming the findings with no evidence of infective endocarditis or masses related to the ring. So the patient was kept on medical treatment for 3 months, yet he's still symptomatic. And coronary angiography was done, revealing a patent grafts, and the mitral valve replacement with a prosthetic mitral valve was done. And 6 months after surgery, the prosthetic mitral valve is well seated and functioning, and the LV size returned to normal with an ejection fraction around 52%. So before we proceed with discussion, do you have any questions about this case?
Dr. Ala and Dr. Tamer, do you commonly see patients with ring dehiscence and severe mitral regurgitation? Of course, we see the paravalvular leak usually with infection.
This is you can see situational references and common view to see in many patients. So it is unusual to see this site for this view we have. And can I ask Dr. Ala, this is a regular site to see situations like that or not?
No, sir. This is not a regular site. The regular site, like Dr. Ahmed said, is a posterior aspect. However, this patient is a classic case of ischemic mitral regurg. Over the last 10 years, we know something from the literature, from reviewing literature. Those patients are best dealt with by mitral valve replacement and not mitral valve repair. This was a change in the decision of mitral valve surgery in case of ischemic mitral regurg. For many years, we kept doing mitral valve restrictive annuloplasty for these patients. What's called overcorrection undersizing by putting a smaller ring to put this mitral ring in place and avoid the enlargement of the ventricle. However, with time, we found that the 2 years follow-up for these cases shows re-regurg in 60% of cases. Most of them will need re-intervention, which will be more risky, especially if the grafts are patent, and the operation will be more risky than if you go for a replacement from the start. So I wanted to give here a take-home message. Which patient is better to go for mitral valve replacement when he has ischemic mitral regurg? 3 patients, well recognized. Number 1, when the ejection fraction of the patient is less than 35%, please go for mitral valve replacement. When the end-diastolic dimension is more than 6.5, please go for mitral valve replacement. And a very important note that should be borne in mind of cardiologists and cardiac surgeons, that if you have an inferior wall dyskinesia or inferior wall akinesia. This is considered by some an absolute indication for mitral valve replacement. If you go for mitral valve repair by a ring, if the size is more than 6.5, ejection fraction less than 30%, akinesia or dyskinesia on inferior wall, you will have absolute re-regurg within 3 years, and mostly it will need re-intervention.
I agree totally with Dr. Ala, and I have to enumerate that if you have the basal segments of the inferior wall of the infralateral wall is dyskinetic or aneurysmal, please don't think about mitral valve repair. You have to do a mitral valve replacement. So let's proceed with the discussion about this case. Although the annuloplasty rings are generally durable over time, ring dehiscence from the annulus is a well-recognized cause of failure of the mitral valve repair. And several large retrospective reports indicate that when mitral valve repair fails, 13 to up to 42% of the time, this failure is due to ring dehiscence. As Dr. Ala said, if you use a tight ring in a markedly dilated ventricle, you are distributing the force around the annulus in an abnormal way. And this force by time leading to the dehiscence of the annulus. So the force distribution along the mitral annulus is not uniform and is variable throughout the cardiac cycle. Also, the collagen content is directly related to the force necessary to tear out an anchoring and neuroplasty stitch, and shedding light on why dehiscence along the posterior annulus is more common. And the collagen density of the anterior annulus is greater than the posterior annulus and therefore can tolerate much higher tensile force. This would predispose to dehiscence along the posterior annulus. That's why we are saying that the dehiscence in our patient is not the common. The common side for dehiscence is usually the posterior annulus. And the true sized ring reduces the contractile forces, which is logical because it is physiologic and does not constrain the annulus. Approximately 30 to 50% of patients will develop ischemic mitral regurgitation after myocardial infarction, and the progressive LV remodeling and dysfunction of the subvalvular apparatus are mainly the causes of the mitral regurg. And the mitral regurg, especially if significant in patients with ischemic heart disease, have poor long-term prognosis. You have now these forces that cause the mitral regurg in ischemic heart disease patients. You have either the annular dilatation, restricted mitral leaflet closure, chordal tethering, posterolateral papillary muscle displacement, and left ventricular dilatation and increase in sphericity. And surgical treatment is centered on mitral valve repair utilizing a restrictive annuloplasty or valve replacement with preservation of the subvalvular apparatus. And this is now the preferred method, as Dr. Ala said. The mitral valve replacement with preservation of the subvalvular apparatus is the way to go if you want to make a competent repair or competent surgery for mitral valve. And the recent cardiothoracic surgical trials network study, patients with severe ischemic mitral regurgitation were randomized to mitral valve repair with a restrictive annuloplasty versus chordal sparing valve replacement and concomitant CABG if indicated. And at 2-year follow-up, the mitral valve repair were associated with significantly higher incidence of moderate to great recurrence of mitral regurgitation and heart failure, with no difference in the indices of left ventricular reverse modeling as compared to mitral valve replacement. So the mitral repair has higher incidence of recurrence due to either to valve dehiscence or due to incompetent technique in the repair of the valve. And also it doesn't change the ventricle remodeling or affect the ventricle remodeling in better way compared to the mitral valve replacement with subvalvular preservation. And the American Association of Thoracic Surgery consensus guidelines reinforce the concept that for ischemic mitral regurgitation, a good repair without recurrence means better than replacement if the valve is suitable for a repair. So you should avoid the 3 patients that Dr. Ala had said about in including them for the repairing of the valve. The markedly dilated ventricle, the basal segments are dyskinetic or scarred. And also if you have an extensively abnormal valve with large stenting area. Although it may be presently popular to state that ischemic mitral regurgitation replacement and repair are functionally equivalent, by far the best LV remodeling occur with a good repair if you select the patient well and if you have a competent surgery that can ensure a good repair. Therefore, identification patient in whom good repair could be achieved is paramount. And we can see here that the selection of the patient depends on the echocardiography mainly, You have, we can see here the mitral valve geometry, interpapillary distance. I don't want to go through these details, but there is a tight selection criteria that the patient that will have a competent repair after the surgery. So you have to select your patient meticulously before sending him for a repair. So my conclusions here that mitral valve repair ring dehiscence is not an uncommon cause of mitral valve repair failure, and the choice of either mitral valve repair or replacement in ischemic mitral regurgitation is challenging, yet if a good repair could be done, then it is a better choice. And thank you for your time.
Thank you, Ahmed, for your nice case. And we can proceed for if any question from the audience. Karim, is there any question for Ahmed?
Thank you, Ahmed. There is a question regarding the intervention in the cases of secondary mitral regurgitation. When to intervene for secondary mitral regurgitation in the absence of any other heart valve or cabbage. Do you prefer to go to surgery in this patient, and when you prefer to do surgery for a patient with secondary mitral regurg in the absence of other open heart surgery?
Yes, that's a good question. The decision here, the degree of mitral regurgitation affects the way you're gonna do revascularization of the patient. So we can see if you have a coronary lesion and you have more than moderate mitral regurgitation, then you should consider to sending this patient for surgery, because with time, this mitral regurgitation will affect the left ventricle more. It may lead to further dilatation and impairment of the systolic function. So if you had more than moderate, grade 3 or grade 4 mitral regurgitation, then the surgery is your option. Then you are faced with another situation. You send this patient for a repair or for a replacement. Then you have a meticulous echocardiographic assessment for the parameters that ensures successful mitral valve repair post-surgery or not. And you should be aware of the level of expertise for achieving a good repair results in your center or the center the patient will do the operation. If all the parameters of the echocardiography goes with a good repair results and your center is expert and has good experts in the mitral valve repair, you can go with the repair. If not all this criteria is fit, go with mitral valve replacement.
May I add something?
Sure.
I think that the question was not about the patient mitral regurg associated with cabbage. Not with he wasn't asking about ischemic mitral regurg. He was asking about secondary mitral regurg without cabbage. He means idiopathic dilated cardiomyopathy mitral regurg. Is there any rule for intervention in it? I think that if we are back to literature, now recently there is a rule, a small narrow window for mitral clip in countries that have that luxury to perform mitral clip. But if you are going to have mitral valve surgery, this is a class 2B indication in the guidelines. Class 2B, this is it's a must to be mitral valve replacement, not mitral valve repair, and it's a must to preserve both leaflets. I did like 20 cases of this category. I can tell my experience in this, that avoid to be very late in the intervention. Do not wait until the ejection fraction is low. Do not wait until the end diastole is very high, because even if you are going to a good mitral valve surgery, this patient dimensions will be better. But actually, very big hearts, as you know, having ectopic foci for abnormal rhythm. I saw those patients may die from ventricular fibrillation, and we do not insert ICD regularly because of its cost. So the intervention in idiopathic cardiomyopathy, severe mitral regurg, is first by pacemaker and non-synchronous pacemaker, second medical treatment and pacemaker, then mitral clip if applicable, and finally you can go for surgery as class 2B indication. And if you go for surgery, go for mitral valve replacement and preserve boost leaflets, and do not wait until the end diastole is very high and ejection fraction is very low.
Okay, Ale, thank you very much for this note. Can we move to the last speaker,
Dr. Mohammed Medhat,
Mohammed
please
Medhat.
share your slide. And again, we have Dr. Mohammed Medhat, lecturer of cardiology at Beni Suef University, and he has an excellent case report regarding a prosthetic valve complication. So please, Dr. Mohammed, go on with your case.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good night. I have a small comment about the last case of Dr. Ahmed Fried. We usually do in echocardiography. When we see the mitral valve in the closed position and in systole, he mentioned the tenting area and the coaptation distance. You can see here at the end of systole, the mitral valve perform a tent in this triangle, this area. If what was more than 3 centimeters square, this is that means that the valves the leaflets are tethered, and this go for mitral valve replacement better than repair. And if the coaptation distance, which is from here to here, is more than 1 centimeter or 10 millimeter, is also unfavorable for repair, and we should go for mitral valve replacement.
An excellent note. An excellent note.
Yeah. Thank you. My case today, I will be short because you are going to sleep now. I have a mechanical prosthetic pulmonary valve malfunction. This patient is extremely unlikely to see in your clinical practice. 35-year-old female. At 2013, she complained of progressive shortness of breath. I made this echo when I was assistant lecturer. It took about 45 minutes to do this echo. I can abbreviate this. As you can see here, she has a VSD, ventricular septal defect, with severe pulmonary and valvular and infundibular pulmonary stenosis, and a mild overriding aorta with subaortic membrane. And the right coronary cusp was prolapsing into the VSD. This is anatomically tetralogy flow, but because of the large right coronary cusp prolapsing into the VSD, and the subaortic membrane that made the left ventricular pressure very high, the shunt was left to right instead of right to left shunt. So this patient was acyanotic. And discovered by me at when she was 30-year-old, about 7 years ago. Okay. At 2014, she had mechanical prosthetic valve in pulmonary position. And I can say that this is the only case I had ever seen with mechanical prosthetic valve tilting this, bileaflet tilting this in pulmonary position. All patients with pulmonary valve nowadays have melody valves, or those valves that are put percutaneously. And she had also closure of the ventricular septal defect with long-term anticoagulation with warfarin, and she disappeared till presentation at 2019. At 2019, she experienced exertional shortness of breath, cough and expectoration of yellowish sputum, nausea and chest burn of 10 days duration. And she was on warfarin 7.5 milligram per day, but not taken regularly. And she had an INR of 1.89. You can see here the parasternal long axis view of the patient after surgery. Here's the aortic valve, diseased aortic valve. And you can appreciate here the subaortic membrane and the VSD that was closed. Closer view. Here's the subaortic membrane. Length about 15 millimeter and 6 millimeter below the aortic cusps. Trileaflet aortic valve. You can see the pulmonary, prosthetic pulmonary valve is not moving, or we cannot appreciate any movement. with color flow Doppler, here dialyzing with pulmonary regurgitation, at least moderate degree of pulmonary regurgitation, and dialyzing. Continuous wave Doppler was done. Clear mild aortic regurgitation, mild to moderate. You can appreciate here the parasternal short axis view with the left ventricle with flattening of the interventricular septum during the whole cardiac cycle, denoting pressure, RV pressure overload. Here the continuous wave Doppler on the pulmonary valve with peak systolic velocity at about 4.5 meter per second, and the peak systolic gradient 81 millimeter mercury, severe prosthetic valve stenosis and dysfunction, obstruction. The TAPC was 2 centimeters with good left right ventricular systolic function, and the S dash or S prime of the tricuspid annulus was about 13 centimeter per second, which is very good. More than 10 or 9.5 is good right ventricular function. And the right ventricle was a little bit dilated, about 4.6 centimeter at the tricuspid annulus. Here we had the fluoroscopy, and you can appreciate here that she has a bileaflet tilting disc prosthesis, and both leaflets are stuck in the mid-open position without any movement. Here. Then what's your choice regarding management of this patient? Would you go for IV heparin infusion or IV thrombolytic therapy or redo valve replacement or intensify oral anticoagulation with aspirin? What do you think?
So let's give 1 minute for YouTube, and while that can Dr. Ala and Dr. Tamer can give their comments.
Okay.
Dr. Ala, we wanted to start with the opinion of the surgeon. What's your opinion?
I think this patient is, if he's hemodynamically stable, he can go for a redo surgery. But if he's not, his general condition is not that good, he can go for anticoagulation therapy, thrombolytic therapy. But I prefer always, if the patient is stable, he can go for a redo surgery because he's young, and this valve will not functioning good for a longer time, as he's just 30 years old.
Thank you. Any comments from the audience, Dr. Karim?
The audience on YouTube, Dr. Muhammad is voting for IV thrombolytic therapy.
Okay, let's see what the guidelines says. The guidelines here state that for management of left-sided, this is not right-sided, for left-sided obstructive mechanical prosthesis, when you see an obstructive thrombus and the patient is not critically ill, then if the patient is not critically ill, then does the patient have a recent inadequate anticoagulation? For our patient, yes, she was on warfarin but not regularly. Then IV heparin plus aspirin. If succeeded, it's very good and for follow-up, but if failed, then go for surgery. But this is for left-sided valves. Then we have this statement from the guidelines. Here, fibrinolysis with unfractionated heparin or streptokinase without unfractionated heparin should be considered when surgery is not available, or is very high risk, or for thrombosis of right-sided prosthesis. The rationale for this is the right-sided prosthesis have a higher incidence of thrombosis because of the slower circulation and the lower velocity of blood flow across. So the stasis predisposed to coagulation and higher incidence of thrombosis here. Then, as the audience chose, we should have IV thrombolytic therapy. We discussed with the patient the pros and cons with the thrombolytic therapy, and the patient refused the thrombolytic therapy for the complication, for fear of the complication of bleeding and intracranial hemorrhage. And we met with her in a mid zone where we can start heparin infusion. And if no response within 72 hours, we will go for IV fibrinolytic. Especially the patient was stable in clinical situation. Here you can see after IV heparin infusion for 72 hours, you can appreciate here the movement of the leaflets of the pulmonary valve. Then this is pre-heparin and this is after heparin. Here no any movement of the leaflets, but here you can see the up and down movement of the leaflets. You can see a very good sign here. The gradient decreased from 80 millimeter mercury to 50 millimeter mercury, 52 millimeter mercury. The moderate stenosis, but the most important is you can see these lines that mean the valves, the mechanical leaflets are moving. This is the acoustic effect of in the continuous wave Doppler. You can see the pre-heparin, there was no movement, and so these acoustic shadows were not present, but here post-heparin infusion, you can see the leaflets, the acoustic effect in the continuous wave Doppler. Here, one of them moved, but the other is still closed. And thank you. The patient is now on intensified oral anticoagulation, and she refused to have fibrinolytic or surgery, being asymptomatic now. Thank you for your attention.
Thank you, Dr. Mohammed, for this elegant presentation and this unusual case to meet in our daily practice. Dr. Mohammed, what about if a patient is hemodynamically unstable? There is now a doctor or physician decision, not a patient. It's okay?
Yeah.
If we have a hemodynamic instability.
If she was unstable?
Yes, hemodynamic.
If she was unstable, we have, and surgery is present and nearby, surgery will be the first option. But if the surgery is not present, we will go for IV thrombolytic therapy if there is no contraindication.
When to start the fibrinolytic and when to start by decision for surgery? When to take decision to go for fibrinolytic and when to I would refer to a surgeon?
If the patient is critically ill and hemodynamically unstable and the surgery is there, then we can go for surgery. But if the surgery will be delayed or the patient has other comorbidities that prevent her from going for surgery, then life-saving is to perform intravenous fibrinolytic therapy.
So no criteria to start with fibrinolytic as a first option?
Yeah, the guidelines was not clear in that.
No criteria in the guidelines.
I think this patient was able to, or would be better for him to have a tissue valve in this position. I wonder why he had a metallic valve in this position. And if he came later for thrombosis, it will be wise to try to explain to him that we may have a redo surgery and put a tissue valve instead of the prosthetic valve, because actually prosthetic valve on the right side, even tricuspid position or pulmonary position, is actually a poor decision for anticoagulation. He will need like INR of 4 to be well anticoagulated, and this is very risky in Egypt because I know 4 may be higher, like 6, and risk of bleeding. And if he is not compliant to Marivan, this valve will go massive thrombosis by time.
Taking into consideration that the patient is a female, a young female at 35-year-old, and a single, she didn't marry yet.
Yeah, I think that tissue valve was a good decision for her.
Yeah.
Another question, dear Muhammad, which is, I think that the most difficult situation is the current situation for this patient. If the patient continued to be symptomatic, so she will have to choose the better choice of thrombolysis or doing another surgery. But now she's a time bomb. She has no symptoms, but she has a partially functioning valve, which can be malfunction at any time, with a limited chance for another hospitalization or another management. So do you have any plan to convince this patient to be directed towards a better plan of treatment, either which is, I think now, is a redo surgery?
The maximum I could get with her is to have intensified anticoagulation regimen with close monitoring for the INR. But the patient refuses any other intervention in the time being.
I think she will think for another intervention if she thinks to get married and get pregnant. Otherwise, she will continue with close observation.
And I want to add a note here. Actually, all over the world now, they are speaking about putting a tissue valve in the pulmonary position always. There is no rule for mechanical valve now. Tissue valve is a must because in the future, if you are going to do a redo surgery, you do not need to do a redo surgery. They are working now, as you know, on melody valve. Melody valve is easily implanted in this position in the upcoming days, and this will be a valve-in-valve technique, and it will lead the patient to be corrected without a new another redo surgery.
So, Mohammed, would you add aspirin to warfarin in this patient?
Sure, we already did.
I think her problem is a very high INR target needed, and should be around more than 3.5. I think about 4.
4 years, 4 years.
Yeah.
It's difficult.
Yes. I think she eventually will need a bioprosthetic valve for correction of this condition.
Yes, especially if she got in need for operation, got in need for dental extraction even. And if she get need for any procedure, it will be in trouble. So I think sooner she will go for tissue valve implantation. Very nice case, Dr.
So thank you, Dr. Mohammed. And a small final comments from Dr. Tamer and Dr. Ala, our moderators.
Yeah, this is a very nice day and very highly presentable and highly illustrative and unusual cases. Decision making was very good. The discussion was fruitful about how to deal, and we apply the guidelines in every case and stick to team management and team decision. So this is our conclusion from the cases today. We should apply to the guidelines. We should have a team between the cardiovascular or cardiology and the cardiosurgeon, and the decision is for the patient benefit usually.
I'm so happy. I'm so happy that I was with you for the first time, and I hope that I will participate.
We all are happy with you.
Our pleasure, Dr. Ala.
Our pleasure.
Thank you.
Thank you, everyone.
Thank you.
So, webinar.
Thank you, everyone.
Thank
you, everyone.
I'd like to thank all speakers, Dr. Hatem, Dr. Ahmed Farid, Dr. Mohammed Medhat. These were very excellent presentations. I'd like to ask our great moderators, Dr. Tamer Mustafa and Dr. Ala Omar, for their inputs and valuable thoughts regarding the management of prosthetic valve disease. And it's actually a prosthetic valve disease, as Dr. Hatem mentioned. So I'd like also to thank all CEC co-founders, Dr. Haytham Sulaiman, Dr. Muhammad Zahran, Dr. Ahmed Saeed, and Dr. Abdurrahman Gamal. And waiting for you next Saturday with the congenital heart disease. And next Thursday, we'll continue the valvular heart disease track with the infective endocarditis, another difficult entity of valvular heart disease. So we are happy to be with you, and have a good night.